Perché tu di chiria io non? Maria?
Hello, everybody. I'm very pleased to greet you in this TIF consensus meeting on the blood safety and adequacy, in which we shall have the pleasure to have 4 speakers for 3 topics dedicated in these issues on blood safety and adequacy. And after these presentations, we shall have the interactive discussion and we shall collect questions and try to correspond and answer to all your comments and questions. So now I would like to ask Dr. Yoon to have the first presentation on global overview of blood safety and availability and the work of the WHO over the years on a recurring global issue. I'm very actually privileged to give a presentation of the profile of Dr. Yoon, who is an eminent colleague dedicated in the issue. She is the team lead for blood and other products of human origin of the WHO. She is a medical doctor's specialization in transfusion medicine, and she has a doctorate in biomedical sciences. She has served for many years as a director of the Central Blood Transfusion Service of the Indonesian Red Cross, and she is the coordinator of the master's program on biomedics with specialty in transfusion science at the University of Indonesia, and the blood services program coordinator at the Directorate of Primary Health Services of the Ministry of Health in Indonesia. Dr. Yoon, you may start, please, your presentation. Thank you.
Good morning, good afternoon, good evening, everyone. I'm Yuyun Marionesi, a team lead for blood and other products of human origin, World Health Organization headquarters. First of all, I would like to congratulate and thanks the International Thalassemia Federation for conducting this internal congress and inviting WHO to share the work of the WHO over the years on recurring global issue on blood safety and availability. I have no actual or potential conflict of interest in relation to this Congress or this presentation. As we all know that blood and blood components are critical for treatment of bleeding due to birth, delivery, injuries, and surgical procedures. blood and blood component is needed for managing the life-threatening condition, for example, for hemophilia, thalassemia, immune deficiency, and cancer. And furthermore, the plasma-derived medicinal products such as albumin, blood coagulation factors, immunoglobulin, and other products also important for managing certain medical conditions such as for bleeding disorders, immune deficiency, and hypoalbuminemia. Some key facts I would like to share with you based on the Global Database on Blood Safety 2018, that of the 118.5 million blood donations collected globally, 40% of these are collected in high-income countries, which is home to only around 16% of the world populations. In low-income countries, up to 54% of blood transfusions are given to children less than 5 years of age, whereas in high-income countries, the most frequently transfused patient group is more than 60 years of age, accounting for up to 75% of all transfusions. And based on samples of 1,000 people, the blood donation rate is 31.5 donations in high-income countries, 15.9 donation in upper middle income countries, 6.8 donation in low middle income countries, and only 5 donations in low income countries. An increase of 7.8 million blood donation from voluntary non-remunerated blood donors has been reported from 2013 to 2018. In total, 79 countries collect more than 90% of their blood supply from voluntary non-remunerated blood donors. However, 56 countries collect more than 50% of their blood supply from family or replacement or even from paid donors. So again, the Global Database on Blood Safety 2018 shows that there are at least 6 main challenges in blood services. So the data from the GDBS 2018 can be accessed to the web link that I provided in this slide. The first challenge is inadequacy in policy, regulations, governance, and financing, in which only 72% of reporting countries has national blood policy and only 64% has legislation on quality and safety of blood. Second challenge is insufficient supply of blood products, in which there are still 62 member states with blood donation rate less than 10 per 1,000 populations. Deficiencies in safety, effectiveness, and quality is the third challenge, where only 80% of donated blood was tested in low to medium income country toward some infectious disease such as HIV, hepatitis B, hepatitis C, and syphilis. Lack of availability of PDMPs again is another challenge, in which in low to medium income countries, only 37 to 69% blood collected separated into components. So this leads to the insufficiency volume of plasma for fractionation. And only 55 out of 170% reporting countries produce PDMPs from their plasma. Suboptimal clinical practices and poor access to blood during emergency situation is other challenges. So this situation because or supported by the data that 128 out of 171 countries have national guidelines on clinical use of blood, and only 50% hospitals has transfusion committee, and only 49% reporting countries has hemovigilance system in place, and only few countries has developed blood supply preparedness systems. What is WHO response to these challenges? So WHO already issued the WHA resolutions. At least there are 3 WHA resolutions which is very important. So one is issued in 1975 on utilization and supply of human blood and blood products. Another is issued in 2005 on designation of 14 June as World Blood Donor Day, and the last one issued in 2010 on availability, safety, and quality of blood products. So the last resolution actually urged all member states to achieve self-sufficiency of blood component for transfusion as well as blood products for treatment. Another response from WHO is establishing the WHO guidelines, aid memoirs, information sheets, general documents, as well as a strategic and plans document, and also conducting the training through, of course, developing the training materials, and also conducting workshop, and also conducting the site visits. I would like also to emphasize that in 2013, WHO has included the whole blood, red blood cells, platelets, and fresh frozen plasma in the WHO model list of essential medicine. This is important because this document, or the inclusion of the blood product into essential medicine, can urge the member states to put more attention on blood system, because as we decide the blood product as essential medicine, so means that this blood product, the availability, of this blood product should be guaranteed, as well as its quality. And furthermore, in 2018, the International Conference of Drug Regulatory Authorities called for strengthening hemovigilance system to monitor the safety of blood donation and blood transfusion. So in this slide, I would like to give you the example of WHO response in guiding member states to achieve 100% voluntary blood donation. So starting with development of the global framework for action on towards 100% voluntary blood donations, guidelines on assessing donor suitability for blood donations, as well as some technical document and recommendation. So including the last one is in 2021, we issued the interim guidance on maintaining a safe and adequate blood supply and collecting convalescent plasma in the context of the COVID-19 pandemic. So all of this document can be accessed to the website link that I provided in this slide. Another example is the WHO response in guiding member states to improve quality of plasma and encourage the fractionation program. So the response is starting with the development of information sheets on plasma contract fractionation program, on ensuring the quality and safety of plasma-derived medicinal products, as well as the document issued from East Mediterranean Region Office of WHO on plasma fractionation program for developing countries. Another important document is a guideline on management of blood and blood component as essential medicine. So all the links to this document is provided in this slide. And progress to overcome challenges. So countries that implement WHO resolutions and guidance document on blood, mostly developed countries, are making progress in providing safe blood and blood products. However, progress in establishing and strengthening national blood system has been slow in many countries. So there is a need to push for implementation of WHO guidance at country level, particularly in low and middle income countries. So in response to WHO Resolution 2010 on availability, safety, and quality of blood products, the action framework to advance universal access to safe, effective, and quality assured blood products for 2020 to 2023 has been launched in February 2020. This action framework aims as a strategic direction to global efforts to address present barriers to safe blood. The document also contains the implementation of the resolution, the goals, and the strategies to cope with the challenges. And lastly, the document also can be used to build the partnership and fundraising. The document proposes 6 strategic objectives to cope the challenges in blood system. So the first strategic objective is appropriately structured, well-coordinated, and sustainably resourced national blood system. Second strategic objective is appropriate national framework followed by functioning and efficiently managed blood services, effective implementation of patient blood management, effective surveillance, hemovigilance, and pharmacovigilance, and last strategic objective is building the partnership, collaboration, and information exchange. So since last year, we tried to implement the action framework in the form to develop some guidance. So at least we identify at least there are 8 guideline or guidance document need to be developed in accordance to each strategic objective. So in year 2020, in line to the strategic objective number 3, functioning and efficiently managed blood services, we have developed 2 guidance documents. So one is the guidance on centralization of blood donation, testing, and processing. And the second document is guidance on increasing supply of PDMPs in low to medium income countries through fractionation of domestic plasma. So why these 2 documents has been put as priority? Because we realize that access to safe blood as well as to PDMPs is still a big challenges for most of the developing countries. And we believe by centralizing the blood testing and processing, the member state can improve the quality of the blood component as well as the plasma for fractionation, and then also it will increase the volume of quality plasma for fractionation. And in this year, we are working to develop 3 other guidance documents, and we are happy to inform you that the policy brief for the implementation of patient blood management and education module on update clinical use of blood, which is aligned with the strategic objective number 4, effective implementation of patient blood management, has already been issued. And the last document that we are working on in this year is the tools for stepwise implementation of hemovigilance system. This is aligned with the strategic objective number 5, effective surveillance, hemovigilance, and pharmacovigilance. We expect that this document can be published at end of this year. And for the 2 years coming, we plan to develop the guidance on blood supply preparedness during emergency situation, guidance on quality assessment for blood products and associated substances, medical devices, including IVD, as well as the guidance on costing of blood services. So here are the link to the recent published guidance from WHO. So the guidance on centralization of blood donation, testing, and processing, guidance on increasing supplies of PDMPs, policy brief on patient blood management, as well as the education module on clinical use of blood. So unfortunately, the iris link to this educational module is still in the process. Hopefully by end of this month, we can share the link to this document. Another activity under the action framework is to give the technical assistance to member states. So of course, this technical assistance should be conducted at 3 levels of WHO. So by the WHO headquarters, regional, and also country offices. And of course should be run in 6 WHO regions. The form of technical assistance are webinars or workshop, twinning program, country assistance, and training program. Unfortunately, due to the COVID-19 situations, the training program, country assistance, and training program cannot be conducted. But hopefully, by the time, if the COVID-19 situation is getting better and traveling is allowed, then these three activity can start to be run. So the recent WHO activities to assist member states is mostly in the form of webinar. So there are some webinar that already been conducted by WHO. For example, the webinar to circulate information on the interim guidance on maintaining blood supply during COVID-19 and collecting and use of convalescent plasma, webinar on strengthening blood system through effective blood regulations, webinar on hemovigilance systems, and also webinar to promote the new published guidance. And all these webinar are recorded, and actually the regional office and country office of WHO can repeat this webinar for their own purpose at the regional or country level. WHO also has supported the webinar on voluntary non-remunerated blood donors during World Blood Donor Day organized by the Italian National Blood Centers. Another training workshop is on global benchmarking tools for blood conducted in July 2021. And also WHO support and involved in some webinars organized by our stakeholders, such as our stakeholders is the International Society of Blood Transfusion and also another stakeholders. So like today, the TIF conducting this webinar and inviting the WHO is a good chance for WHO again to disseminate the information of the existing WHO guidance document. At regional level, the AFRO, so the African Regional Office of WHO, and also the Southeast Asia Regional Office of WHO are also actively to conduct the webinar on some aspect of blood transfusion services. Was my presentation. I would like to conclude that WHO resolutions has urged member states for self-sufficiency of blood products. Numbers of WHO guidance documents are available to guide improvement of quality of blood products. Government commitment, robust blood regulatory and well-coordinated blood system are needed to be in place to overcome challenges. And lastly, partnership and collaboration with international and national stakeholders play key roles to assist countries to improve their blood system. So thank you for your attention.
I would like to thank you and congratulate Dr. Yoon for this excellent presentation, really, and the overview of the work of the WHO over the years on a recurrent global issue. And now we go on with our program, and I would like to call Dr. Lakshman Eddy Shinke, Director of the National Blood Transfusion Service and Chief of the WHO Collaborating Center in Sri Lanka, to give a presentation on the Sri Lankan experience for the work of the WHO Blood Reference Center in Asia and Middle East region. You have the floor, please, 10 minutes if you like, and then we shall have the Iranian experience by another colleague. Thank you.
Hi, I'm Dr. Lakshman Eddy Singh, Director National Blood Transfusion Service, Sri Lanka. Greetings from Sri Lanka for all the listeners. And also I would like to take this opportunity to thank the organizers for inviting me to make this presentation on behalf of the National Blood Transfusion Service of Sri Lanka. So if there are total strangers to the Sri Lankan profile, I would like to give us sort of a very brief outline about the Sri Lankan profile. Sri Lanka is a small island nation located in the Indian Ocean. And our total land mass is around 65,000 square kilometers. Our population is nearly 22 million. and we are a very small economy in Asia. It's around 84 billion US dollars annually, and our per capita GDP is to 3,852, and we have a fairly good human development index of point 0.78. So, which indicates that we achieve all these things under a very low resource setup. So this is the purpose of our existence as the national blood transfusion in Sri Lanka. So this is our vision and mission statements. So our vision is to be a unique model for the world, securing quality assured blood services through a nationally coordinated system. And our mission is to ensure the quality, safety, adequacy, and cost effective of the blood supply, related laboratory, clinical, and academic and research services in accordance with the national requirements and the WHO recommendations. So Sri Lanka is having the national blood transfusion service as a nationally coordinated system. So that coordination is brought about by the national policy. So we have a national blood policy introduced by the ministry, sponsored by the Ministry of Health, under which all the governance and the regulatory mechanism operates throughout the country. So under this national policy, the sole supply of blood and blood product to the nation is under the purview of the National Blood Transfusion Service. So the chief executive officer or the director of the organization, director is the chief executive officer when it comes to the blood and blood related products in Sri Lanka. So for the easy management, we have divided the country into 24 clusters. Each cluster is headed by a consultant transfusion physician, under which we have 102 hospital-based blood banks and 2 standalone blood centers to deliver our services e equally on equitable basis throughout the island. This is our annual collection. So it ranges from 400,000 to 450,000 annual collection. And this is entirely voluntary, non-remunerated donations. We achieved this feast in year 2013. Before that, it was, proportionately there was a non-voluntary donation or directed or replacement donation. There was a sizable proportion coming to our system before 2007. In year 2007, government took a commitment with the National Blood Transfusion Service and our health department to embark on a program to convert our total collection into a 100% voluntary, non-remunerated donation program. So which became successful in year 2013 due to a very high commitment coming from all the stakeholders from top to bottom. So we celebrated and we achieved that feast in year 2014 at the national level. Then at the moment we are a WHO collaborating center in the Southeast Asian region. So myself is the head of the WHO CC, and all our cluster consultants contribute to the work of these WHO collaborating center work schedules as persons. And under the WHO collaborating center, we undertook 3 main areas to carry out our work. So one area is training and education. When it comes to the training and education, we train all our National Blood Transfusion Service staff members. So that has 2 components. One is the induction or the recruitment level. We do an induction training for all the technical categories of work that we recruit for the National Blood Transfusion Service Sri Lanka. Other than that, we conduct in-service training program for all our technical staff members in the service in year-out basis as a routine training program. And then we give training facilities for these external individuals, for the postgraduate and undergraduate trainees in the Ministry of Health as well as Ministry of Higher Education of Sri Lanka. Apart from this, because of the WHO collaborating status, we conduct training program for the regional countries. If they need our technical expert sharing, so we ready to conduct training programs under the themes that is mentioned in this slide. So this is highlight of one such incident. Very recently, we conducted certain training programs for certain regional countries who required our services to update the knowledge of their technical members. But over the last 1.5 year period, because of this COVID pandemic, that we could not conduct external training programs for the regional countries for obvious reasons. And this is, creating awareness among the school children and the general public. This is how we achieved our 100% voluntary donation. The other main contributory work we do for the WHOCC is the development of IEC material for our purpose and as well as for the regional countries who need our services. Certain IEC materials we have already developed but these are yet to be validated and to be distributed among the international level. That is, it will be ready soon for the distribution. There will be many more material developed in this manner. They are ready to be developed very soon. And the other thing is to assist the WHO in implementing quality system in the blood transfusion services. All our services in Sri Lanka are quality assured. Our quality levels are maintained throughout the country. The same quality standards are maintained. So we have these things, documented. Our operation is well documented in a quality manual. We got the ISO certification very recently, a couple of months back. Now this is ready right now. We can share it and we can publish and we can share that knowledge and experience even within the zero region countries. So if we need any other external people, if they need our assistance, so we can share our expertise on the quality assurance systems, how we conduct under a very low resource setups in Sri Lanka. When it comes to the thalassemia situation in country, so this is the commonest genetic disease in Sri Lanka, and our state is, we are in an intermediate prevalence state, Sri Lanka. So we have 3,500 patients in our registries requiring our services through blood transfusion. Majority of them are thalassemia major, and beta thalassemia is the prevalent variety in Sri Lanka. And in Sri Lanka, the prevalence is not uniformly distributed throughout the country. Certain provinces, certain districts are in high prevalence, especially the northwestern, the north central, and the central provinces. But the other areas, the prevalence is very low. And so according to our calculation, 10% of the annual transfusion is going for servicing these thalassemia patients. So that is all is my presentation. So I will make myself available if during the discussion period, if further clarifications or queries are there to answer. So thank you very much for patience listening.
Thank you very much, Dr. Eri Disinke. Excellent presentation and congratulations for the program that you have implemented in your country as regards the WHO quality issues. And I was very pleased to see the increasing rate of the blood collection by voluntary blood donors. And now I have the pleasure to invite Professor Eshki to give a presentation on the Iranian experience. Dr. Eshki Piman is a professor of pediatrics, hematology, and oncology. He is a managing director of the Iranian Blood Transfusion Organization and chief of the WHO Collaborating Center in Iran. You have the floor, please. 10 minutes.
In the name of God, the most compassionate and the most merciful. We're going to talk about blood safety and adequacy and experience of Iranian Blood Transfusion Organization. IBTO, which was established in 1974, is a centrally coordinated blood transfusion service with a national authority to codify the related regulation of blood transfusion in different fields. Iran is the first country in the Eastern Mediterranean region which reached 100% voluntary, non-remunerated blood donation and collects 1.5 times more blood compared to other upper middle income countries. Iran has the highest rate of yearly blood donation in this region. Although, as we can see in this slide, there are few countries in the region that hold blood donation more than 20 per 1,000 population, but none of them has 100% voluntary non-remunerated blood donations except Iran. 35 years after establishment, IBTU reached to the peak of the trend of yearly blood donation at 2012. But after 2016, it gradually started to decrease due to starting tests only for first-time donors, source plasma collection, and COVID-19 pandemic. As I mentioned, the reasons for a declining trend of blood donation collection since 2012 in Iran were the start of exclusion of first-time blood donors, a project which started in 2016 to increase blood safety in 10 provinces and then gradually expanded to all of the country. To the start of source plasma collection by plasmapheresis, which started in 2016, but in about 16 centers, but stopped in 2020 due to failure to increase the total net volume of collected plasma, despite of its severe negative impact on the attitude of voluntary non-remunerated blood donors and declining trend of whole blood collection. COVID-19 pandemics that clearly impacted on whole blood donation all around the world, changing age patterns of blood donors in Iran, and deferral and rejection of donors due to changing lifestyles such as tattoo, bloodletting, nutrition, some medications, medical interventions such as colonoscopy and endoscopies, and increase in high blood pressure donors and so on, and limited resources due to sanctions and health expenditure of COVID-19 pandemics. As you can see here, the peak age range of blood donors shifted from 25 years old to 35 years old from 2012 to 2020. And you can clearly see here that older age groups increased and the younger age group decreased during last 6 years. And in this regard, the frequency of first-time blood donors decreased and regular and repeated blood donors increased during last decade. So we decided to focus on first-time donor return rate because we found that donor return rates during the first year were relatively low, even in countries where success in recruiting new donors. In Iranian studies, we found that successful return to donation rate at about 50% in some period of times. And mean first-time donor return rate in Iran during second half of 2020 was 30%. So this return rate has become one of our main goals since 2020, because increasing the return rate of first-time donor would substantially increase the donor pool. Another issue was high total deferral rate in Iran, which was not related to low hemoglobin level as was shown in other countries in the region. The trend of all blood products in Iran were in parallel with the trend of whole blood donation as was shown before. However, regarding to production and distribution of local reuse RBC to the thalassemia centers, we had increasing and steady state during recent years, and also single donor platelets was increasingly produced and distributed to the hematology and oncologic services that was expanding in Iran. After 2018, the main transplantation centers in Iran, hospitals in Iran, were equipped with radiation machines, and the number of irradiated blood components which is produced and distributed by IBTO were decreased. Regarding to blood safety in Iran, Iran is among the high-income countries in terms of blood safety, as you can see in this slide that has been published by WHO. The trend of prevalence of TTIs in blood donations and screening in Iran were decreasing during last 10 years very clearly. However, in 2020, it was a little increase in rates of HPS and HCV in our screening results. These slightly increase in TTI's screening tests were mainly due to influx of first-time donors, which was evident in other disaster situations, and also decline in regular blood donations, because most of Iranian regular blood donors are middle-aged who were more involved with COVID-19 and avoided to donate during this period. And also transient impact of shifting from ELISA to ECL and CL method on initial reactive results. Non-availability of confirmatory tests in some period during the pandemics due to sanctions that lead to a lack of surveillance of the reported seropositive cases, and also stop in pre-donation screening program regarding to blood shortage in COVID pandemics and decline in first-time donor return. Regarding to impacts of COVID-19 on blood safety and sufficiency in Iran, it was a worldwide decreasing trend of blood collection all around the world, decreasing from 30% to even more than 60%. It happened in all of the countries, developed or underdeveloped, Eastern Mediterranean region, and even USA. And obviously, Iran was one of the most involved countries in the world and in the region, with 5 crises and outbreaks. We published our experience to overcome this problem in detail, and our experiences were cited in WHO guidelines. The mean rate of blood shortage in Iran was less than 9%. That was clearly less than the rate in the region, and it was mainly due to significant reduction of number of blood collection, lapsed, and regular blood donation. However, the rate of distribution to request, rate of platelet and packed RBC, and even local reduced RBC never decreased to less than 85% during last 2 years. Meanwhile, we started to collect convalescent plasma from recovered patients in Iran 2 months after pandemics, and about 16,000 units were collected, and 12,000 of them were distributed. All of them were titrated against anti-spike antibodies. More than 50% of them were high titer. And after monitoring and collecting the follow-up forms, we found that the time intervals between hospitalization and injection in patients who died was significantly longer than patients who were discharged, and patient outcome was significantly better by plasma injection within the first 5 days of hospitalization than after 5 days. Finally, we conducted and cooperated in one case series study, another case control study, and a clinical trial. 2 of them are published, and 1 of them are going to be published. And a epidemiological studies also were done by us on the prevalence of anti-SARS-CoV-2 among asymptomatic blood donors in Iran. Thanks for your attention, and I'm ready for any questions that you have. Thank you very much.
Thank you very much indeed, Professor Eshki. Great progress you have achieved in your country, and thank you very much for presenting the impact of COVID in blood safety and availability in Iran. And now I have the great pleasure to invite Dr. Androula Eleftheriou, a great friend, first of all, to give a presentation on the Global Patients Perspective, TIF's 2021 Global Review, and the need for an international alliance of patients for blood safety and adequacy. Androula is a very special person with tremendous organizational and scientific abilities. She has obtained her graduate and postgraduate degrees in biochemistry, microbiology, virology, and business administration from the University of London, and she has received many fellowships from the WHO and the Fulbright Commission. She has worked as a chief of the Virus Reference Center of the Cyprus Ministry of Health, and since 2006, she has become the heart of TIF. She is the executive director of the Thalassemia International Federation. And last but not least, Androula Eleftheriou is an expert patient advocate. And now I really have the pleasure to present to you Dr. Androula Eleftheriou. Androula, you have the floor, please.
Distinguished chairperson, presenters, ladies and gentlemen, dear friends, it is my pleasure and an honor to present on behalf of Thalassemia International Federation the work of TIF towards identifying the needs and towards promoting activities and services towards addressing more effectively the unmet needs of patients, in assessing the extent and quality of the services provided for their care across the globe, and in particular in this presentation regarding the quality of transfusion therapy services, and perhaps to advocate and confirm for the need of an international alliance of patients for blood safety and adequacy. This presentation will be referring to hemoglobin disorders and impact very shortly in this special audience. There is no need and will be an exaggeration to talk about hemoglobin disorders and what these are and what their impact is on the safety and availability of blood for patients with hemoglobin disorders, and will be an overview of the findings of the Global Thalassemia Review 2021 And the next steps that Thalassemia International Federation is proposing as a call to action and the development and establishment of Patients International Blood Alliance as a need to address some of the gaps and the many weaknesses in the blood transfusion care of patients across the world. Now, hemoglobin disorders of the hemoglobin molecule of the red blood cells, which are caused by a genetic mutations at the level of controlling either the production of hemoglobin, as in thalassemias alpha and beta, according to the chains that are absent or largely absent alpha or beta thalassemia, and controlling the structure of the hemoglobin molecule, as in the case of the qualitative abnormal hemoglobins of variants. The most important clinically is hemoglobin S, causing the sickle cell disease. And indeed, the studies on the molecular genetic level have been more extensive than studies on the care of these disorders across the world. And there has been numerous studies to relate genotypes with phenotypes and predict the clinical manifestation of these diseases and their needs for care, including transfusion therapy. Now, both thalassemia and sickle cell disease, if not early and accurately diagnosed and provided appropriate management, can lead to multi-organ dysfunctions and high morbidity rates, leading to early mature death. Now, based on the knowledge and experience compiled through successful programs initially by the Southern Mediterranean countries, namely Italy, Greece, and Cyprus, but also on the way and through the years by others, it has been demonstrated that the journey of a patient with hemoglobin disorders, and here is the example of a patient with thalassemia, is difficult, painful, challenging, but can be successful and lead to increased survival, good quality of life, and social integration if there is an early and accurate diagnosis, referral of patient to well-trained healthcare professionals in trained, experienced treating centers who undergo lifelong professional education, access of these patients to appropriate multidisciplinary care and reference centers, and integration and referral to appropriate social care, state and disease-related social care, integration of research and innovation, and participation in clinical trials to contribute on a continual improvement of the care and drugs provided to these patients, and through education, patient education, the meaningful and patient engagement at all levels. All of these elements integrated into disease-specific national programs of prevention and management, including, very importantly, the use of a disease-specific registry, and coordinated by the national healthcare system of a country that includes the two important characteristics of patient-centeredness and universal health coverage. And indeed, where such programs have been implemented, there has been an impressive improvement in survival and quality of life, social integration of patients, and even for non-transfusion dependent thalassemias, for which there was a period of time that they were all considered as phenotypically milder types and no need for early diagnosis and monitoring. It has been in very recent years shown that early diagnosis, monitoring, and treatment can decrease significantly the high rate of morbidities of these patients as well. Notably, these patients constitute a very big percentage of the global thalassemia population around the world. Therefore, the two most important components in a national disease-specific program include prevention and clinical management, with all the elements essential in each component: screening, prenatal diagnosis, genetic counseling, and registry in the area of prevention, guidelines, reference center, availability and accessibility to drugs in the case of clinical management. Now, despite the fact that there is an absence of national registries across the world and absence of updated, upgraded epidemiological work or new, well-designed studies in still large populations across the world, leading to a gross underestimation of the figures, yet the figures that are published today, like 5 to 7% of the global population carrying an abnormal hemoglobinopathy gene, 100,000 and 300,000 annual affected births with beta thalassemia major and sickle cell disease respectively, as well as living more than 500 patients with beta thalassemia major and millions of sickle cell disease patients, the accuracy of which is unidentified yet, demonstrate that these diseases are a growing health. They cause immense medical, public health, social and economic repercussions in more than 70% of the countries of the United Nations, where nearly 90% of all births are happening globally. And one of the 5 common disorders, birth defects, accounting for 25% of all birth defects on a global level. And the occurrence of these diseases, despite the belief in the very early years of the geographic confinement of these diseases, and in particular of thalassemia around the countries of the Mediterranean Sea, through the work of World Health Organization and others through the years, it has been very well demonstrated, and for some time now, that hemoglobin disorders are occurring widely across the world, and that active population movements and migration have literally introduced this disorder into the indigenous populations of almost every country around the world, including Central, Western, and Northern Europe, where these diseases were not known, challenging significantly public medical health systems around the world. Now, the absence of disease-specific registries, epidemiological work, micromapping, leading to gross underestimation of carrier rates, annual affected birth morbidity and mortality rates, have indeed contributed to the absence or prevention of the accurate assessment of the contribution of these diseases to the national and international disease burden, although some significant progress has been achieved in the assessment of disease burden in the case of sickle cell disease due to the much greater number of these patients. So these disorders are still considered as largely neglected disorders, and the greatest majority of patients are receiving suboptimal care across the world. Now, with regards to blood transfusion, which is the subject of our discussion today, blood transfusion has been shown since the very early years, as shown on the bottom of this slide, that it increases the survival of patients that were considered to having a fatal childhood diseases from the first decade to passing the second decades of life. But of course, these depending on the quality and effectiveness of transfusion, and certainly with the addition of other management protocols and interventions, mainly iron chelation, multidisciplinary care, we've seen the impressive increase in survival. Now, safety and availability of blood are indeed of critical value to patients, and not only to transfusion-dependent beta thalassemia major, but to a very big number of non-transfusion-dependent thalassemias, previously considered or still considered as of milder phenotypes, but which at some stage, for known and unknown reasons, as we see on the red arrow on the right, may progress to more severe disease and become even transfusion dependent. A number of studies, recent studies, have tried to relate the genotypes of these non-transfusion dependent hemoglobinopathies with the potential or the prediction of when and where they will lead to transfusion dependency. There's more work still ongoing, but what it is important is that a significant percentage of patients are dependent for their life and health and quality of life on safe and adequate blood. More than 80%, however, of our global patient population is born and lives in those countries where blood adequacy, safety, and other pillars of management, including chelation, are sadly suboptimally provided. Now, what does effective transfusion mean in the case of patients with hemoglobin disorders? Well, these are very well and comprehensively described, as seen on the right side of the slide, in recommendations encompassed in international guidelines as TIF guidelines, very recently publishing and distributing its fourth updated and upgraded edition. Now, effective transfusion means adequacy and safety. These are the two pillars of effectiveness, and adequate means enough blood to raise the pre-transfusion hemoglobin at all times more than 9 grams, between 9 to 10.5, which are those levels which have provided evidence of combating the results of the genetic damage, the severe anemia, the bone marrow hyperplasia, the organomegaly, and other consequences, and bring about normal growth and physical attainment. And safety means not only appropriate screening for preventing transmission of blood-borne pathogens, but very importantly, appropriate processing in terms of matching, antibody screening for avoiding development of adverse reactions and alloimmunization, filter blood, appropriate storage and appropriate age of blood to be provided in order to counterbalance the deficiency of the genetic damage, providing the erythropoiesis and ineffective erythropoiesis. We need fresh blood with oxygen to be transferred across the cells and tissues, organs of the body for their normal function and growth. And very importantly, the third element is the increase and strengthening of the voluntary non-remunerated blood donation practices. And it has been shown beyond any doubt that such practices contribute significantly to the safety of blood. And the Global Thalassemia Review 2021 published as a result of the collaboration of TIF with World Health Organization in its plan of activities between 2018 and 2021 has shown very well some of the weaknesses and gaps in the care provided to patients across the globe, including transfusion therapy. The aim of this report was indeed to capture the patient's perspective with regards to the extent and quality of services they receive, including blood transfusion services in their countries. The information was compiled through patient-oriented surveys, questionnaires, webinars, and official reports by collaborating healthcare professionals and, in many countries, competent health authorities. So some of the care elements studied in this report include the blood, the iron load, multidisciplinary care, social health care, and discuss the effectiveness of the various prevention policies and programs across the globe which is a very important element contributing to the improvements of services, including blood transfusion therapy in countries where there is effective prevention of these disorders. And the global review has, in addition, highlighted the big value, the significant value of the meaningful and productive patients' engagement at all levels and at the level of decision making. So with regards to the patient's perspective on the care they receive in the context of blood transfusion services, the Global Thalassemia Review touched on 3 pillars for the sake of presenting the patient's review in terms of the extent and quality of care they receive in transfusion therapy: adequacy, processing of blood, and age of blood. And these responses demonstrate that a significant percentage of the patients reported postponements and a big percentage regular and frequent postponements of blood transfusion therapy. They reported as having pre-transfusion hemoglobin less than 9, which is what the international guidelines recommend. A big percentage, over 50%, between 7 to 8 pre-transfusion hemoglobin, but a significant portion, nearly 20%, report as having pre-transfusion hemoglobins less than 7, while only around 12% report as skipping at all times pre-transfusion hemoglobin over 9. With regards to family and friends replacement donation practices, a big percentage, nearly 80% of the patients report as having the burden of identifying family and friends to donate for the needs of their blood transfusion therapy, whereas nearly 16% they report reliance at times, while over 30% report regular reliance on family and friends' donations to address their needs. And only just above 10% are actually reporting as having the knowledge that their blood is derived from 100% voluntary non-paid donation practices. With regards to processing of blood, sadly nearly 20% report as receiving whole blood, but fortunately 85 and just over 85% report that they are only receiving rarely whole blood, but nearly 15% report as having receiving a rare whole blood more than 5 times a year, which is significant and very important for the care of these patients. Now, nearly 90% of the patients report that they are not aware of how their blood transfusion services work in their country and what is the processing process for the blood they receive. The only element that they were, in a majority of them, aware to report, nearly 70%, was that they receive unfiltered blood. The majority on occasions, less than 10 times a year, but a good percentage of nearly 35% receive unfiltered blood, quite often reporting more than 10 times a year. The age of blood is also of concern, as reported by the patients themselves. Only around 10% receive fresh blood less than 14 days, but over 70% they report as receiving blood aged more than 14 days, with nearly 70% of whom between 15 to 20 days, and a percentage of nearly 30% of older than 20 days. Impressive were the conclusions of treating physicians, or the responses of the treating physicians in 38 countries, 150 treating centers, where more than 80 and nearly 90% of all of them reported that hemoglobin disorders did not constitute part or did not constitute a priority on national health agendas. There were no adoption of international guidelines for their management, and therefore there was inconsistent care protocols across the countries. They felt that a more robust, centrally coordinated transfusion system with strong chemovigilance and patient blood management programs were in need, as well as improvement in the voluntary non-paid blood donation practices. But what is impressive is that more than 90% of them reported as providing insufficient, or confessed rather as providing insufficient support for the transfusion-dependent patients with regards to adequacy and processing of blood. And in an effort to grade the effectiveness of transfusion centers, of transfusion services in some of the regions of the world, and despite the fact that in some of the region, excellent transfusion centers are in place, and even WHO collaborating transfusion centers, as a whole and as on average, the average is assessed in a different way. The two parameters that we touched on was the scoring of the pre-transfusion hemoglobin responses, as well as the number of postponements of transfusion appointments per year. So the European and American region are seen as the best in providing these two parameters at an adequate and appropriate level, while Eastern Mediterranean and even more particularly the Southeast Asian region are areas where considerable improvements and significant gaps and weaknesses are met as expressed by the patients. Now, challenges were also investigated in the course of the COVID-19 pandemic. Challenges faced by transfusion-dependent patients across the world. The two important components faced by all, irrespective of the country they live in, whether high or low and middle-income countries, where the reduced or confined access to blood transfusion centers and the interruptions in blood transfusion therapy appointments. The reduction or the confinement of the interactions were magnified in the low income countries, as seen on the orange bars. These challenges also occur in medium and high income countries, as seen on the blue bars, but they occurred across universally. However, in the high income countries, this was a temporary situation of less than 8 weeks, whereas in the low to medium income countries, this was a longer period of time. In the low-income countries, some of the challenges seen was the increase in provision of whole blood and provision of unfiltered blood, as well as hold of iron chelation, the duration of which is still unknown, and TIF is investigating whether these challenges and these weaknesses have indeed been reversed. Now, this complicated and difficult to interpret from a distant slide accumulates the results of the Global Review 2021, including the patient's perspective in assessing the extent and quality of the care they receive, including transfusion therapy. And the information, as previously mentioned, gathered in this report supported the assessment and grading of the countries according to the effectiveness of the different care services provided to patients. Now, in this table, there was an effort by TIF to include the economy and the level of public health services in the countries in order to possibly relate the effectiveness or ineffectiveness of the care provided to these patients with the economy and the public health level existing in the country. And in this context, the Human Development Index and the income group, as defined by UNDP and World Bank respectively, and the public health level as defined by infant mortality and under 5 years of age rates were included. And indeed, it was seen that the economy and the financial constraints as well as the level of the public health care were closely related to the effectiveness or ineffectiveness of the care provided to these chronic diseases. But what it really demonstrated was that the majority of patients across the world, in more than 80% of the countries studied in this report, nearly 50, were faced with many multiple unmet needs across all services of the care, demonstrating the huge inequalities which are prominent within and across countries of the region, and certainly reflect to the huge violation of their rights. And this is sad because there is ample evidence, knowledge, and experience of how to appropriately treat and effectively prevent these chronic diseases, either through the experiences of countries, but very importantly, through the incredible work of some bodies, and mainly of World Health Organization through the years since 1975. And this is only focused on the guidance given in blood safety and adequacy alone. There are other resolutions and knowledge of World Health Organization guiding on prevention and management of these disorders through resolutions, executive board decisions, reports, notably the action framework to advance universal access to safe and effective assured blood between 2020 and 2023, but other important bodies like the European Commission, as well as the Council of Europe, and other regulatory bodies such as CDC, AAB, and International Society of Blood Transfusion contribute significantly with education and other guidance on how to improve safety and adequacy of blood. So TIF has contributed to the efforts in improving blood safety and adequacy since its establishment, since blood transfusion therapy is one of the two main cornerstones of management in the context mainly of its educational program, conferences, events, publication, courses, fellowships, but also through its contribution to World Health Organization and European activities in the context of contribution to consultations, resolutions, and action plans. Collaboration with professional societies like the International Society of Blood Transfusion and the European Hematology Association, as well as collaboration with universities, expert centers, and official partnerships with important relevant bodies, including the United Nations and the Council of Europe. So the call for action, this is how TIF believes the next steps should be, because more than 50% of the blood supply in the 56 countries of collecting blood are dependent on family and replacement practices. And 42% of the nearly 120 million blood donation units come from high-income countries, which make only 16% of the global population. One can estimate the weakness in the rest of the countries where more than 80% of our population lives. So TIF believes in the stringent adoption of the World Health Organization resolutions and investing on tools and on blood, stronger patient advocacy, and establishment of synergies and networking with other disease-specific associations like the World and European associations of hemophilia and rare anemias, for the promotion of improvements in transfusion services, hemovigilance, and clinical use of blood, strengthening the recruitment and sustainability of the voluntary blood donations, continuous medical education of treating physicians, but also transfusion specialists. Importantly, the building of diversity in the blood donor pool to meet the ever-increasing ethnic diversity with population and migration movements across the globe. Very importantly, to introduce, implement and monitor the effectiveness of patient blood management programs and introduction of innovation and research that would provide the blood more appropriately, investigating the cost of anemia prior to providing transfusion, and innovations such as this happening in thalassemia that may affect and limit the transfusion dependency. Well, stronger advocacy for universal health coverage is amongst our major goals, as also is the goal of the United Nations in its Sustainability Development Goals for 2030. So what we have proposed is the establishment of an International Blood Alliance, Patients International Blood Alliance, PIBA, that will So,
thank you very much indeed, Dr. Eleftheriou, for this
very sorry for this
fantastic
very
talk.
long presentation. So very sorry. We should have cut the introduction because in this very special audience, everyone knows about hemoglobin disorders. But thank you very much, everyone. Dina, the floor is yours for last conclusions.
Well, thank you so much, Andrula, first of all, for this great talk. You have explained why safety, quality, and adequate and availability of blood is of critical value in the patients with thalassemia, major, and hemoglobinopathies. I hope that we have some comments and answers to the speakers, and we are really ready to receive your comments and answers, or if the speakers would like to exchange some views and have questions to other speakers, I think it will be fine.
I would like to thank the incredible work that is being done by World Health Organization, but also by other reference centers such as the Iranian Blood Transfusion Center, with which we have been working for very long with Iranian patient associations and healthcare professionals, as well as in Sri Lanka. And perhaps in the alliance that I'm proposing as a Patient Blood Safety Alliance International, I'm hoping that these distinguished people running the WHO collaborating centers will contribute significantly to develop better advocacy and improvements in blood transfusion therapy.
Actually, if we have a few minutes still, I would like to ask the colleagues from Sri Lanka and Iran what is their plan, national plan for the development of a national hemovigilance system in their countries, which is something, it's a very important, it will be an important development for safety, quality, and availability of blood as well.
Dina, if I may interrupt, I pay my sincere apologies to you as a chairperson, thanking you, and to each of the distinguished guests. I have to leave because of this delayed session. We are starting a very important board meeting that I need to be present. But I leave you in the best hands of the coordinator, Professor Konstantina Polidi, and my very best wishes and sincere gratitude to for your contribution. Thank you.
Okay, Andrula, thank you. All the best for your next session.
Thank you
very much, and congratulations for the work done by TIF. Okay, thank you very much. So, what Dr. Yoon would like to tell us in a more specific way about the new program for the development of national hemovigilance systems in the countries.
Dr. Yu?
Is it a question for me or for who?
Well, it is a question for all of you. First of all, I would like to ask the Iranian and the Sri Lankan colleagues, the two of them, to see if in their plans for the further development of blood safety and quality in their countries, they are planning to start establishing, implementing a hemovigilance system in their countries. And then, if you would like to say a few more about the WHO's plan for this particular issue.
Okay, so maybe I can give some comment first.
Dr. Eshki, or who would like to say first?
Okay.
Can you hear me? Can you hear me?
Yeah.
Yes.
Yes, we can hear you.
Yes. Yeah. Thank you very much for this interactive discussion with countries' problems and same challenges. Iran has established a national hemovigilance system since 2009, and it was an process in our country, and now we have more than more than 96% of our hospitals all around Iran, not just academia centers. All of the hospitals around Iran is under supervision of NHS, National Hemovigilance Service, and it's a must criterion for hospitals to get certificate by the MOH to be verified and qualified by NHS. Our Iranian Blood Transfusion Organization in all of our 31 provinces around Iran, and supervise all of the blood bank systems and the process of delivery of blood and distribution, and also usage of blood in the hospital, and recording and report the probable come to the IBTO, and also the proper services in the laboratory blood banks in each hospital. In this, if the hospital been verified and confirmed by our hemovigilance service, hospital is accredited every year, and this is established in about 96.
Thank you very much for this information. I would like now to ask our colleague to know what is happening in Sri Lanka as regards this issue, and whether the hemovigilance plan program is addressed to the patient, patient who is receiving blood components, or as well to the donor. Do you also plan to develop a hemovigilance for the donor?
Yeah, I mean, I couldn't mention it in my presentation. Yes, we do have a hemovigilance system in operation in Sri Lanka. I mean, both ends are covered, the donor as well as the patient. And very recently, we introduced sort of a further step, updated sort of a hemovigilance system. In that one, now we have instructed all our peripheral blood banks who are based in hospitals to generate a zero report, at least, to keep the system alive. That is sort of a weekly zero reporting system that is made a routine operation into the system. So at the moment, it is a paper-based system. We have a small issue with our electronic system right now, but we are very much hopeful by before the end of January next year that we are going to make it also electronically online system to send their reports through the internet, so that will become a web-based operational system. And also we have, as I described in my presentation, for the ease of administration of the National Blood Transfusion System Sri Lanka, we have divided our system into 24 clusters. These clusters are headed by a consultant transfusion physician. So when the incidents are reported, these cluster consultants, they will call hospital based the transfusion review meetings with the clinical colleagues as well as the transfusion side colleagues. So they will sit together. These are non-fault finding missions just to rectify the errors. I mean, that is not to penalize anybody, in a disciplinary way, but to find, to maintain our safety and the quality standard. So that is the operation that in Sri Lanka at the moment. Those are running without major issues right now.
Thank you very much. I suppose you are talking really giving emphasis on the value of having hospital transfusion committees in all
That's right.
hospitals in your country. And now I'm sure that Dr. Yun would have a lot to say, not only on this issue, but on everything, because of the great plan of the WHO to improve safety and availability for transfusion-dependent patients and their life, actually, but also for so many other issues which are applying to transfusion medicine. Yoon, you have the floor, please.
Thank you, Professor Politis. So I think from my presentation, based on the global database on blood safety 2018, hemovigilance system is one of the challenges faced by most of the developing country. And I think some barriers for this situation is, first, the data shows that only 50% of hospital has established the transfusion committee in their hospital, and then also there are lack of awareness among clinicians to implement the clinical use of blood and also patient blood management. So I think this reason then lead to the difficulty in implementing the hemovigilance system. However, as I mentioned again in my presentation, this year we try to we are working to develop the tools tools for stepwise implementation of hemovigilance system. So hopefully these tools can be published at end of this December. So the tools consist of step-by-step guidance for the country on how to set up or establish the hemovigilance system. So for example, in these tools, we explain that the country can start to establish the hemovigilance system at the hospital level. So then maybe this hospital level hemovigilance system can be expanded to other hospitals, and then slowly then we can go into the national hemovigilance system. So this is about the hemovigilance system.
Thank you very much. I also really like to stress the great value of the patient blood management and hemovigilance. These two programs together can really provide a great, these are tools, great tools really for the blood transfusionists as well as the clinicians, people working in transfusion medicine altogether. Thank you so much. I don't know if any of you would like to ask each other for any other issues. Yes, please.
Just add the most important point in hemovigilance system is right recording and report of the centers, and it should be supervised person by person and physically, not just trust on the electronic reporting. Needs an active presence and of hemovigilance team from the transfusion organizations in each hospital at least once or twice per year, because right reporting and right recording document and documentation, especially for the complications of blood transfusion, is very important to have a good insight on the treatment.
Allow me to say that I fully agree with this principle that you have mentioned now. And in this context, I think when we are talking about the clinicians, I would like really to say that we do not mean only just the medical people, but also the nurses who have to be educated in all aspects of transfusion medicine as well as for hemovigilance. They can play a great role in these issues. What do you think? What do the other colleagues think in this forum? We all agree on that?
Yeah. I think I agree. Not only the nurse and also the medical students and also another people who involved in the transfusion practice.
Absolutely.
So including the blood center staff also should be aware of this clinical use of blood and patient blood management practice.
You are saying that the curriculum of the medical students in transfusion medicine should really include patient blood management and hemovigilance as well. Yes, these are really excellent things. Thank you so much. I think now that as there is not time probably for questions and comments from patients and parents or colleagues outside of this forum, we can still invite people, whoever would like to send comments and questions online, and we will, in connection with TIF, we shall manage to send them to the speakers, and everybody can have answers and to their questions. Is anybody who would like to make any other point, to bring into question something else that we have not touched, or to advise TIF for something?
I just want to congratulate TIF for having the survey on the unmet need of blood for transfusion from the patient perspective. So I think this survey is very good to make a clinician and everybody aware that the blood supply is still a problem. Thank you.
Okay, thank you very much. I think it's time now to really close this session and congratulate again for your presentations, and a great thank to TIF for providing this the step for this forum. Thank you very much indeed.
Thank you. Bye-bye.
Thank you.
Bye.